Hi students, this is a review of Chapter 13, or the Respiratory System. As you can see here that the whole chapter is included, you want to exclude though the parts 13.10 and 13.11. And here's a list as usual of what is included and what is not included in these slides. So a little intro on the respiratory system. It is very closely associated with the cardiovascular system in order to bring in oxygen to the body and transport that oxygen to the cells while getting rid of carbon dioxide. Respiration really involves these 5 different steps. So first off, there's pulmonary ventilation, which is basically breathing air and moving air in and out of the chest. And then there is exchange of gases at in the level of the alveoli. So that would be exchange of oxygen and carbon dioxide between your alveolar air and the blood in the capillaries, and that is known as external respiration. And then the blood has to transport oxygen and carbon dioxide between the lungs and between the tissue, and that is really a function of the cardiovascular system. And then we have the exchange of gas that happens in the level of the tissues, and that is known as internal respiration. And when oxygen is delivered to the cells, it uses it for cellular respiration, which is, production, glycolysis, electron transport chain, and the Krebs cycle, and so on. So the production of ATP. And that's how we produce that carbon dioxide. Okay, so what are the functions of the respiratory system? So we already said it provides oxygen to the blood. It gets rid of carbon dioxide that is made through cellular respiration and other metabolic reactions. It is important in the regulation of the pH, or hydrogen concentration, in our bloodstream, and that is in coordination with the kidneys. So again, that very infamous reaction that is going to haunt us during this chapter, just like it did during the urinary system, where carbon dioxide combines with water to make H2CO3, which is carbonic acid, and then H2CO3 dissociates into H, that's where your hydrogen ion comes from, and HCO3. So that hydrogen ion, again, you want to associate the presence of carbon dioxide with the presence of that acid, okay? And that's where the pH goes down in the presence of carbon dioxide. The respiratory system is also important for speech, okay? So the function of phonation, the larynx that has the vocal cords is part of this system. It also defends against inhaled microbes. So we'll see how the cilia and the mucus that are made by parts of the respiratory system help in protecting us. And if we ever do get a blood clot, say in our lower limbs, and these clots travel all the way to the pulmonary circulation, while the pulmonary circulation has a way of dissolving those clots and getting rid of it. Okay, so that is also one of the functions of your respiratory system. So the organization of the system, we start off with the nasal cavity. Okay, and the nasal cavity drains all of the paranasal sinuses. Okay, the paranasal sinuses are the frontal, right above the eye, and then we have your ethmoidal and sphenoidal and maxillary air sinuses. All of these 4 sinuses drain into the nasal cavity. We also have the pharynx, and with pharynx is that, we kind of talked about it in detail when we discussed the digestive system. It is shared between the respiratory and the digestive system. The larynx, that's where your vocal cords are. And up until the larynx, any infection in any of these areas is considered an upper respiratory tract infection. Anything beyond the larynx would be a lower respiratory tract infection. So trachea, these bronchial branches, what is known as the bronchial tree. And then the lungs, we have a right and a left lung. The right lung has 3 lobes, so 1, 2, and 3, while the left lung only has 2 lobes, 1 and 2, because in this area we have the heart, and that kind of diminishes the space that is found on the left side of the chest. Okay. For the airways, so we kind of talked about these already. There's a whole part of these airways, that is actually a conducting zone. Okay, so remember when we said that the larynx is kind of that border line between upper respiratory and lower respiratory tract. Larynx is considered part of the upper, and anything beyond the larynx, okay, is divided into two different zones. There's the conducting zone, meaning that it's pretty much just pipes to take the air into what is known as the respiratory zone. So in the conducting zone, there is no exchange of gas. Okay, the bronchi and the bronchioles, all of those have a very thick layer, thick walls. There is no exchange of gas. That's why it's known as the conducting zone. It's also known as the dead zone, meaning not that they're dead tissue, but meaning that there's no gas exchange occurring in those areas. And that will basically take you all the way down to the respiratory zone. Okay, that extends from your respiratory bronchioles all the way to the air sacs. So we'll take a look at the different names. We have the trachea, the bronchi, primary, secondary, and then tertiary bronchi. And then you have these bronchioles and terminal bronchioles. All of that is your conducting zone. Okay, that is part of what is known as the anatomical dead space, meaning that under normal circumstances, healthy individuals no exchange of gas occurs in this area because that is not its function. The only function of that zone is, as the name, implies, is conduction of air to reach the respiratory zone. Now, starting at the level of the respiratory bronchioles, and then alveolar ducts and alveolar sacs, these walls are thin enough and they are surrounded by a large amount of capillaries, and that's where the gas exchange can happen. And there has to be, so we'll take a look over here where you could see these capillaries, okay, surrounding the respiratory zone. And this would be a branch of the pulmonary artery that has the deoxygenated blood coming from the right ventricle. And then exchange of gas occurs in here. Well, the circulatory system is going to get rid of that carbon dioxide and pick up oxygen into these little tiny branches. Those will gather as four pulmonary veins that are going to eventually dump that oxygenated blood into the left atrium. And there has to be a ratio of 1:1 between ventilation and perfusion. So ventilation means the amount of air reaching these alveoli, and perfusion means the amount of blood that is found in these capillaries. So keep that ventilation-perfusion ratio in mind, because we're going to talk about it again when we talk about some disorders of the pulmonary system. Now, one of the things that the respiratory system can do to protect us is what is known as the ciliary mucus escalator. The respiratory bronchioles have epithelial that are ciliated, meaning they have these cilia that kind of work as brushes that have these peristaltic wavy movements pushing things out of the respiratory tract. And we also have mucus cells. Okay, so these mucus cells are going to be secreting mucus. So if we inhale anything that is a foreign body, a dust particle, something basically that's not air, it is going to be trapped by mucus, and then some of them can be engulfed by macrophages, while others are going to be trapped by that mucus and then dusted away through that peristaltic movement of cilia, and we cough those out. Okay, so we're going to cough it out because of that ciliary mucus escalator, and some of the times we end up swallowing most of that, and they'll get destroyed in the digestive system by the acidity of the stomach. One of the effects of tobacco smoking is that it kills the cilia. Okay, so you kind of, you've lost that ciliary movement, and it also irritates the mucus glands to produce lots of thick mucus, okay, because of that chronic irritation by tobacco. So now you have thick mucus, you've lost the ability you've killed the cilia, and that is the reason chronic smokers have that chronic, very characteristic chronic cough that is kind of sometimes known as smoker's cough. Now, what are the functions of the conducting zone of airways? Well, it produces this low resistance pathway. So they're wide enough in order to help in the flow of air into the respiratory zone. Okay, we mentioned that it had the cilia and mucus, so it helps in defending and tries to trap any microbes or foreign bodies trying to get into the respiratory zone. It also is important in warming and moistening the air before it reaches the alveoli. And it also helps in the production of sound. Okay, so the air that we kind of move in and out through that conducting zone is what is going to pass through the larynx, through the vocal cords, and produce different sounds. So what about the gas exchange portion? That happens in the alveoli. Okay, those are the sacs at the very end where they are lined by a very thin layer of simple squamous epithelium. And you'll find that anywhere where you need gas exchange by diffusion are lined by simple squamous epithelium. So, if you go back to your capillaries, you'll find that same kind of epithelium. The alveoli has two different kinds of cells. There is the type 1 alveolar cells, and those are your flat epithelial cells that we just talked about. And there's a type 2 cell, and type 2 cells make surfactant. Okay, so the air sac is surrounded by interstitial tissue, which has hydrostatic pressure, and basically the alveolus wants to collapse because of that hydrostatic pressure. In order to overcome that surface tension of the water, these type 2 alveolar cells make surfactant, and that surfactant overcomes that surface tension. Okay, know that surfactant is made later in pregnancy, so if a baby is born prematurely, they might not have enough surfactant to survive, and that's one of the reasons, something to kind of keep in mind, which we're going to be talking about maybe in the next slide or two. So this is, is kind of a depiction of the parts of the alveolus. You'll find here, this is your capillary where your red blood cells are found in. And here is your type 1 alveolar cell, that flat, simple squamous epithelium. And then your type 2 cells that make surfactant. Okay, the alveoli are actually, if you look, this is healthy alveoli, you'll see here that they're all kind of opened up to each other. So if for some reason this is damaged, the air can kind of flow into the healthier alveoli and not be trapped into this one. For the pleural membranes, which would be the serous membrane surrounding the lungs, those are known as your pleural sac. It is made out of two different layers. The visceral layer, that is the layer that is directly attached to the lung tissue, while the outer layer is the parietal layer, and that is attached to the chest wall from the inside. It lines the interior thoracic wall and the upper surface of the diaphragm. There is a space between these two layers, and that is known as the parietal sac, or the parietal cavity, the pleural cavity. And there is a very thin layer of serous fluid known as the intrapleural fluid. Okay, because of the hydrostatic pressure of that fluid, there is an intrapleural pressure found between the visceral and the parietal layers. So we'll take a look in here and kind of, explain how these two layers are formed. So if you think of a balloon filled of water, and you punch it, and then you kind of get these two different layers, this would represent your parietal layer, and that surrounding the lung or the hand in this experiment would be the visceral layer, and that would be the space in between with the water filling up that space. So if we take a look at the lungs here, we have the parietal layer that is surrounding the internal thoracic wall and the upper part of the diaphragm, while this is the visceral pleura that is right on top, directly attached to the lung tissue itself, while this space, that pleural space, is full of a very thin layer of serous fluid. Okay, and if for whatever reason the pressure inside of this water increases, so let's say somebody gets stabbed and there's now bleeding into that space, okay, which is a condition known as hemothorax, that is going to increase the pressure in the pleural sac, and that is obviously going to push or compress the lung tissue, deflating the lung tissue, and it can lead to what is known as lung collapse. Okay, so these are different pressures that we are going to be discussing as well. Now, steps of respiration, okay, that we talked about at the very beginning. Now we're going to get into more detail. So your first step, let's first of all take a look at what we're looking here. This right here represents the air sac and the atmosphere. That is your arterial or oxygenated blood, taking it to the cells where cellular respiration is happening. And then this is your venous system, taking back that deoxygenated blood back to the lungs. So your first step in respiration is ventilation, and that is basically the air going in and out, exchange of air between the atmosphere and between the alveolus. And then there's the exchange of gas that happens in the lungs, and that is known, we call that external respiration, and that happens by simple diffusion, where oxygen diffuses into the capillary and carbon dioxide diffuses into the air sac. Now this oxygenated blood is going to be carried, pumped by the left side of the heart to the different tissue. At the tissue level, there is another exchange of gas that happens, and that is known as your internal respiration, where oxygen diffuses to the cells and carbon dioxide diffuses into the capillaries. Now, this deoxygenated blood is going to be carried by the venous system to the right side of the heart and then pumped back to the lungs in order to get oxygenated again. And this whole process keeps on repeating. So what are the principles of ventilation? So ventilation is the exchange of air between your atmosphere and the air sac or the alveolus. And the, kind of law of physics is that the flow of air is directly proportionate to the difference in pressure and inversely proportionate to the resistance. So let us translate that into terms of lungs, okay? So flow of air, exchange of air between the alveolus and between the atmosphere is directly proportionate to the pressure difference, meaning that there has to be a difference in pressure between the atmosphere on the outside and the lungs on the inside in order for air to flow. So when we inhale, you take a deep breath, that decreases the pressure in your lungs. So air is able to flow from the atmosphere that now has a higher pressure towards the inside of your lungs. If we look at the effect of resistance, if there is bronchoconstriction, so there is constriction of the bronchi, say, for example, during an asthmatic attack, that is now, you've now increased the resistance to airflow, which is going to decrease the amount of air being able to reach the lungs. So what is the relationship required for ventilation? It depends on whether you're inhaling or exhaling. In the incidence of inhalation, okay, you want the pressure in the alveolus to be less than the pressure in the atmosphere. Okay, because air is going to flow from an area of high pressure to an area of low pressure. While if you're exhaling, you would want the opposite. So when you're pushing air out of your lungs, you have to increase the pressure in the alveoli. It has to be higher than the pressure in the atmosphere. Now, what does Boyle's law say? Boyle's law states that the pressure is inversely proportionate to volume. Okay, and I'm going to kind of go to the next slide to explain better how this works. So this syringe will show you what happens during inhalation. If you pull that downwards, that is going to so you've increased the volume inside of the syringe. That increase in volume decreases the pressure on the inside, and that's what Boyle's law states. Boyle's law states that an increase in volume decreases the pressure. Okay, when you decrease the pressure on the inside of the syringe, that is going to pull air from the outside, and that's what you do again with your lungs. When you contract the diaphragm, okay, the diaphragm goes down. That increases the volume in the chest or in the lungs. According to Boyle's law, that is going to decrease the pressure inside of my alveoli, and that's going to pull air from the atmosphere. Now, this side represents exhalation, where, if you push that outwards, you have now decreased the volume, hence increased the pressure, and that pushes the air towards the outside, towards the out of the syringe. And that again is what happens during exhalation. During exhalation, the diaphragm relaxes and goes back to normal, that decreases the area in your lungs, and that increases intra-alveolar pressure, and hence you're going to push that air out into the atmosphere. Now for all of these pressures that we're talking about, we really didn't say any numbers, we didn't say how we measure it or in what units do we use, and all of these respiratory pressures are related to the atmospheric pressure. Okay, at sea level, the atmospheric pressure is 760 millimeters of mercury. So imagine having 760 millimeters of mercury, a tube full of, with this amount of mercury in it. The pressure exerted by that column of mercury would be equal to 1 atmospheric pressure. Okay, so that again is at sea level. When you go above sea level, the amount of air on top of you is less, and that's why the atmospheric pressure goes down as you go to higher altitudes. Now we have what is known as transmural pressure. Trans means across something. Okay, so transmural pressures means pressures that are across a wall. And in order to calculate it, it would be the pressure on the inside of the wall minus the pressure outside of that wall. Okay, and we have these different pressures that we are going to be talking about, and I'm going to go to this image and then go back to those slides. So what are we looking at here? We have the green line that represents your chest wall. Okay, and that chest wall, if it is left free, okay, by its elastic recoil, by the connective tissue and the muscles, it would expand outwards. Okay, so again, if you've seen or if anybody had a rib fracture, they would know that one of the signs that you would see would be that the chest wall is going to pop out. Okay, so your chest wall, because of that elasticity that is in the muscle fibers and in the skin and so on, it has that tendency to recoil outwards, while because of the elasticity of the lung tissue, that wants to recoil inwards, meaning that the lung tissue wants to collapse. So we have these two different pressures that are, in play. Your chest wall wanting to recoil outwards, while the lung, by the elastic tissue, wants to recoil inwards. While there is that third pressure, which is the pressure inside of the pleural cavity. So that is your PIP pressure, intrapleural pressure. And that is going to help in preventing the lung from collapsing and preventing the chest wall from popping out. And that is due to these transmural pressures. So the first transmural pressure we'll talk about is across this wall, which is your chest wall. So you have the atmospheric pressure that is 0, while the pressure inside of the pleura, PIP, would be intrapleural pressure, is -4. So if you do the math, we said that transmural pressure is the pressure inside of the wall minus the pressure outside of the wall. So if you do the math here, -4 minus 0, so this PCW, that stands for the pressure of the trans chest wall, would be equal to -4. While this transmural pressure, okay, known as the transpulmonary pressure, would be the pressure across the lung. So you have on the inside of the wall or in the alveoli, the pressure is 0, while the intrapleural pressure is -4. So again, if you do the math, 0 minus -4 basically goes into 0 plus 4, which is +4. Okay, so you have a +4 pressure and a -4 pressure, and both of these are going to balance each other out. And that's what we were talking about here. So you have your transpulmonary pressure, and this is how you calculate it with the numbers. And that transpulmonary pressure is the pressure that opposes the inward elastic recoil of the lung. While the pressure at the chest wall Okay, that -4 is the pressure that opposes the outward elastic recoil of the chest wall. Now, we kind of talked about already what happens if the intrapleural pressure increases. We said, if somebody has hemothorax and blood accumulates due to maybe a stab wound or what have you. In this case, we're talking about a pneumothorax, so maybe that stab led to the introduction of air instead of blood. That is known as pneumothorax. Now the intrapleural pressure is increased. It's going to push the lung, deflating it from air, and that leads to lung collapse. Now, what are the sequence of events, during inspiration and expiration? First off, during inspiration, okay, you have to contract the diaphragm and the internal intercostal muscles. When you do that, that is going to, again, expand the thorax, so you increase the volume, and that is going to make your pressure decrease in the alveoli. That is going to lead to the expansion of lungs. Now that alveolar pressure is now below the atmospheric pressure, so air is going to flow into the alveoli. The muscles that we used in inspiration, at rest, we are going to use the diaphragm. During forced inhalation, we can use more muscles like the pectoralis minor muscle, for example, the sternocleidomastoid, and these scalene muscles. All of these muscles are going to pull the thorax open, increasing the diameter, increasing the volume of the chest wall. Now, the sequence of events during expiration, we have now the diaphragm and the intercostals are going to relax. Okay, so by the elastic recoil, passively, the lungs are going to deflate or start deflation. And that leads to increased pressure inside of the alveoli, higher than the atmospheric pressure, and that is going to eventually push air out of the lungs. And here for the muscles of respiration, at rest, we really don't have any. All you have to do is relax, relax the diaphragm, and by the elastic recoil, the air is going to be pushed out. But during forced expiration, we can use the abdominal muscles and the internal intercostals. I believe during inhalation, I said internal intercostals. Please go back and change that to external intercostals. Now, lung compliance, that means, how malleable is the lung tissue, okay? So the magnitude of change in your lung volume produced by any given change in the transpulmonary pressure. And it's really determined by two different things: the stretchability of the lung tissue and the surface tension that is present in the alveoli that, again, we are able to overcome by surfactant. So here's when we talk a little bit more about surfactant. It's made by the type 2 alveolar cells. It is a mixture of phospholipid and protein. It overcomes the surface tension that is produced by the water surrounding the alveoli. And surfactant increases the lung compliance. The problem with surfactant is that it's not in a fetal lung tissue. It is made or produced very late during pregnancy. It is stimulated by, at the end of pregnancy, there is kind of like this surge of cortisol, which normally happens, and that stimulates the alveolar 2 cells, these type 2 alveolar cells, to make surfactant. But in cases of premature labor, they miss that cortisol surge, okay? And that can lead to what is known as respiratory distress syndrome of the newborn, where that premature infant doesn't have that surfactant and has lost that ability to get rid of the surface tension. It makes it harder for these babies to breathe. Okay, it can either lead to lung collapse and even death. So the therapy that we use nowadays is put these babies on a mechanical ventilator. If we know, if somebody has a known history of going into premature labor, we could sometimes give that mom, a shot of cortisol to stimulate the baby to make its own surfactant. If it's too late, the baby's already out, so we can also administer surfactant, either natural or synthetic surfactant, given through the infant's trachea. Now we're going to talk about the airway resistance and some of the diseases that occur due to increased resistance to airflow. So as we said, that the bronchi in the conduction zone are wide enough in order to decrease resistance to flow, and that helps in the flow of air. But the respiratory ones, we can actually change the radius of these different zones. Okay, so there are different factors, like physical factors, cold or hot weather, for instance, neurological factors, so parasympathetic and sympathetic, different chemical factors that can affect the radii of these airways. Asthma, for example, is considered a hypersensitivity to different things, okay, depending on patients. Some individuals have it because of exposure to cold weather or exercise-induced asthma, or different allergens that can lead to these asthma attacks. And asthma is really, there are three different things that are occurring during asthma attack. First off, there is constriction of the bronchioles, okay, or bronchi, so that is your bronchoconstriction. So you're decreasing the radii of these bronchi, and that increases the resistance to airflow. There's also increase in mucus production, okay, and there's also an increase in inflammation. So that inflammation, that chronic inflammation that can sometimes happen of the airways, that is going to further decrease the radii of these bronchioles. Okay, so again, this is just kind of a list of different things. Some are induced by exercise, especially if in cold, dry air. Some are induced by tobacco, environmental pollutants, viruses, allergens, and it's a very wide range of different triggers. Everybody's different on what triggers their asthma attack. So your aim of therapy is to reduce the chronic inflammation, okay, and to decrease that hyperresponsiveness. So you do that by anti-inflammatory drugs. For example, leukotriene inhibitors. So one of the first things would be, for instance, montelukast, which is Singulair. Okay, that is a leukotriene inhibitor that decreases the inflammation. Okay, or sometimes in acute. So if somebody has bronchial asthma and then they get maybe a viral infection on top. Their asthma was controlled, but now that they have this viral infection, it's exacerbated. You can give them for a couple of days that inhaled glucocorticoid to kind of, control it. Okay, sometimes these are given in combination. So inhaled glucocorticoid plus the leukotriene inhibitor. Leukotriene, we already said, is like Singulair, while the inhaled glucocorticoid, for example, Symbicort. Okay, your second aim in therapy would be to overcome that, that hyper response to these different things. So to prevent the bronchoconstriction, so you can give them a bronchodilator, like albuterol, for instance. Okay, that is going to dilate the bronchi. Albuterol acts on these beta-2 adrenergic receptors. Okay, so remember, beta-2 adrenergic receptors is a subtype of receptors that are stimulated by epinephrine. And so we're basically increasing the stimulation by the sympathetic nervous system, which means you're dilating these bronchi. Okay, so you're mimicking, you're not actually stimulating the whole sympathetic system, but you're stimulating these receptors. So you're kind of mimicking the effect of epinephrine on these beta-2 receptors, and that leads to bronchodilation. Or another way to do it would be to block the parasympathetic receptors. So we could use like a muscarinic cholinergic receptor blocker, and that is going to prevent the bronchoconstriction. Now, COPD, which stands for chronic obstructive pulmonary disease, that refers to either emphysema or chronic bronchitis or a combination of the two. So, and most of the time, it's actually a combination of the two. So let's talk about what is emphysema. Emphysema is the destruction of these smaller airways. And when you destroy these smaller airways, there are different ways to destroy them that we're not going to get into. That is going to lead to the collapse of these airways, and you have now prevented ventilation from happening in those parts of the lungs. While chronic bronchitis, that leads to chronic inflammation and chronic production of excessive mucus. And as we mentioned before, this can happen due to in chronic smokers, for instance, okay? And individuals who smoke for a very long period of time, they eventually develop that chronic bronchitis. They even start to develop emphysema, and they can eventually develop COPD, where there's a combination of both of these together. Now, these are the lung volumes and the lung capacities. Okay, so if you've ever been to a pulmonologist who's a pulmonary doctor or an allergist, they give you something to breathe in and out of, and that something is known as a spirometer. And they are testing these different respiratory volumes or different lung volumes and lung capacities. So we'll go over them. We have this tidal volume. Okay, and the tidal volume is the amount of air that you breathe in and out at rest. Okay, so that's just basically amount of air at rest. You're not inhaling deeper or exhaling deep. Just your regular breathing in and out at rest. And you can see it has that wavy appearance, and hence the named tidal wave. Okay, it's about 500 milliliters, which is meaning about half a liter. And then you have this inspiratory reserve volume, which means that after a normal breath, you are asked to inhale as much as you can. Okay, so you take your normal breath in first, and then you're asked inhale as deep as you can. That was known as your inspiratory reserve volume, meaning the maximal amount of air you can inhale after a normal inhalation. Okay, the expiratory reserve volume, okay, it kind of works the same way, but it's the opposite. So the expiratory reserve volume is the maximal amount of air you can exhale after a normal exhalation. Now the residual volume, so after you're asked to exhale as much as possible, there is going to be some air left in your lungs. You are never going to be able to exhale all of the air that's found in your lung, or your lung will collapse, okay? So the volume of air that remains in the lung after a maximal exhalation is known as the residual volume. Some of the other capacities, so a capacity means kind of adding one or two or more volumes together. So we have the functional residual capacity that is equal to the expiratory reserve volume plus the residual volume. The vital capacity, and this is one that is very clinically important. So it's definitely done if you're asthmatic, if you know somebody that is asthmatic, this is the test that they will do every 6 months to make sure that that person is controlled and there is no decline in their respiratory functions. And it's basically, you ask the patient to inhale as deep as possible and then exhale as much as you can. Okay, and for kids, they show them a picture of a birthday cake and they ask them to blow out all of the candles. So they tell them to take a deep breath in and then deep breath out. Okay, and that is going to again measure the vital capacity, which is one of the most clinically important capacities. The inspiratory capacity would be the inspiratory reserve volume plus the tidal volume. The total lung capacity would be adding all of these different volumes together, okay? Again, a volume would be just one of these, while a capacity would be adding two or more volumes together. So here's a table with the different definitions. Don't worry about the numbers. Do worry about the definitions though, and how to calculate different capacities. So what is the anatomical dead space? We already talked about it, but since it's talked about again in the chapter, we'll go over it a little bit in more detail. So the anatomical dead space, remember that as the air is going to flow beyond the larynx, it'll get into the trachea, primary, secondary, tertiary bronchi, all of these where there is no exchange of gas, and we named that the anatomical dead space. So the tidal volume that we just mentioned is 500 milliliters in volume. Not all of that is reaching the alveolus. 350 is going to reach the alveolus, and that's going to be used for exchange of gas, while the remaining 150 is going to remain in those conducting airways. And so that is how big your anatomical dead space is, provided that the lungs are healthy. So alveolar ventilation. So if you want to calculate how much air is reaching the alveoli per minute, you would have to subtract this whole tidal volume, okay, minus that anatomical dead space to get to that 350. So you want to find out how much air is reaching the alveolus and then multiply it by the breathing rates per minute. So your alveolar ventilation is equal to the tidal volume minus that anatomical dead space per each breath times the respiratory rate. So how many breaths are being taken per minute. And this alveolar ventilation is a true representation of how much air is actually reaching the alveoli, and you're ignoring the anatomical dead space because, again, it has no role in gas exchange. Okay. So a summary of typical blood flow and how much carbon dioxide or how many carbon dioxide molecules does the body make per each oxygen molecule. So you guys should be able to go through this journey by now, where we start off here in the air and exchange of gas and the alveoli, where oxygen is transported to the cell. The cell uses the oxygen for different metabolic reactions and produces carbon dioxide. Now that's what we're going to be calculating, this respiratory quotient. That is the ratio of carbon dioxide molecules produced to the amount of oxygen or the oxygen molecules that are consumed. Okay. The respiratory quotient for carbs is 1, meaning that for each oxygen molecule that I obtain from a carb, I am going to make one carbon dioxide molecule. While that for protein is 0.8 and for lipids is 0.7, meaning for proteins, for each 10 molecules of oxygen I use, the body is going to produce 8 molecules of carbon dioxide, and you should be able to translate what that means for lipids. In a balanced diet, so somebody is taking in a balanced diet, balanced amounts of carbs, proteins, and lipids, that RQ ratio is 0.8, which again means for every 10 molecules of oxygen being consumed by the body is producing, in the cells, is producing 8 molecules of carbon dioxide. Now, how is it that oxygen and carbon dioxide are diffusing, and how is it that they know which direction they should be diffusing in? That is due to the difference in pressures. So diffusion, if you guys remember, is a passive movement from an area of higher concentration to an area of low concentration. So if you remember from chapter, I don't even remember what chapter this was, but where we were talking about diffusion being a passive mechanism where molecules go down the slide without any energy in an area of high concentration to an area of low concentration. And that's how oxygen and carbon dioxide are going to diffuse. So when it reaches the lungs, these numbers are there just for illustration. So the deoxygenated blood coming from the right side of the heart has a 40 millimeter mercury of oxygen, while the alveolus has 105 millimeter of oxygen. So the oxygen is going to diffuse from an area of high concentration to an area of low concentration until they become pretty much equal. Okay, so exchange of gas, whether we're talking in the alveolus or in the tissue, are going to occur because of that difference in pressure, and it happens until we reach a state of equilibrium. And then these molecules are going to move on to where they need to go. So what are the effects of various conditions on alveolar gas pressures? So realize that the pressures that we're going to be talking about here are the pressure of oxygen in the alveolus or the pressure of carbon dioxide in the alveolus. So we're not talking about blood levels, we're talking about alveolar levels. So let's say somebody is at high altitude, breathing air at a low oxygen pressure level. So obviously the levels of PO2 in the alveolus is going to decrease, but there is no change in the PCO2 levels. Increased alveolar ventilation without any change in metabolism. So think of somebody that is having maybe a panic attack and they are hyperventilating. So that is increase in alveolar ventilation. Okay, so that hyperventilation without any change in metabolism. So the patient is not exercising and that leading to that hyperventilation. They are just hyperventilating without any increase of metabolism. So that hyperventilation is going to lead to increased oxygen levels in the alveolus and washing away a lot of that CO2. So there's going to be a decrease in CO2 levels. Well, compare that to somebody who has decreased alveolar ventilation with an unchanged metabolism. So think of somebody that is holding their breath, but they are not exercising. So their metabolism hasn't changed, but there's a decrease in ventilation because of them holding their breath. That is going to decrease the levels of oxygen and increase the levels of carbon dioxide in their alveoli. Now, this other scenario where there is an increase in metabolism with an unchanged alveolar ventilation. So you want to think of somebody maybe that has hyperthyroidism. Okay, so the hyperthyroidism, these hyperthyroidic patients, they have an increase of their metabolic rates, but they are not hyperventilating. Okay, so now they have increased metabolism and throughout all of their cells, they're producing lots of CO2, but there is no change in alveolar ventilation rates. So their CO2 is going to increase while their PO2 is going to decrease in the alveoli. Another scenario is where metabolism is low, no change in breathing rates. So metabolism is low, you can think of a patient that has hypothyroidism, so they have a less than normal metabolic rate, and there's no change in their breathing rates. Because of that decrease in metabolism, there is a decrease in the levels of carbon dioxide and an increase in levels of their oxygen in the alveoli. Now, the balancing happens when there is a proportional change, whether increase or decrease, but in this scenario, we're talking increase. So a proportional increase in metabolism and alveolar ventilation. So think in this scenario, somebody that is exercising and they are breathing faster due to that exercise. So they have increased metabolism because of the exercise and increase in alveolar ventilation because of the faster breathing rates. Their levels of oxygen and carbon dioxide in the alveoli remain unchanged because there's a balance between increase in metabolism, where on the other hand, there's also increase in ventilation. Now, the control of ventilation perfusion matching. And this is, if you guys remember the very beginning here when we talked about this slide right here. Okay, I asked you to remember that when exchange of gas happens, we talked about this ventilation perfusion match, where there has to be a match between the amount of air entering and the amount of blood coming in. And I asked you to keep that kind of in the back of your head so that when we get to this part, we could understand how this works. So the ventilation perfusion matching, again, means that the part of the lung that is getting the air is healthy, while the amount of blood reaching the lung through the blood vessels are healthy as well. If there is a disease in either one, whether, in the lungs preventing ventilation, proper ventilation, or in the blood vessels preventing proper perfusion of blood, that is going to lead to certain changes. So we'll see what happens if there is an area of lung tissue that has a decreased airflow. So let's say somebody has lobar pneumonia. Okay, so we'll kind of take the right lung for an example where there are 3 lobes, and let's say that one of those 3 lobes has pneumonia. So what is going to happen to all of that air that is now unable to reach that one pneumonic lobe? So we have decrease in ventilation in that one lobe. What about the blood that is going there? Okay, what happens is that there is going to be a shift, okay, that decrease in oxygen in that pulmonary blood that is perfusing to that diseased area, that these blood vessels are going to vasoconstrict and shift that blood to the healthier 2 lobes. Okay, so in order to make sure that there's always a match between ventilation and perfusion. Whenever there's a mismatch, the body tries to correct that. Okay, let's see what happens if there is something going on with the perfusion. So maybe somebody got a blood clot into one of the pulmonary arteries and there is less perfusion or not enough blood flowing to a part of the lungs. Okay, so that decrease in blood flow to a region of the lung is going to decrease the pressure of carbon dioxide in that alveolus. That is going to lead to this reflex bronchoconstriction. Okay, so now that airflow that is reaching that now not perfused part of the lung is going to be shifted to the healthier parts. So you're always going to divert the blood or the air away from the pathological areas into normal areas to maintain a proper ventilation perfusion ratio. Now, a little bit on hemoglobin. So hemoglobin are made out of 4 units of this, okay? So this is just one of the 4 subunits where iron is in the middle and it's going to carry one of these oxygen molecules. Okay, when it reaches the tissues, this oxygen has to let go of that hemoglobin molecule, okay? Now, the hemoglobin does not have a brain, okay? It doesn't know, or there are no signs in the cells to tell it that you're now in a cell, you can let go of the oxygen. There are certain things that help that dissociation of oxygen from hemoglobin, and that is what we call it. If you calculate that, it'll give you a curve known as the hemoglobin oxygen dissociation curve. And that is the curve that we're talking about here. That when, you can see that curve that plots the changes in pressures of oxygen against the saturation of hemoglobin by oxygen. So in the venous system, where the pressure of oxygen is 40, you'll see here that the hemoglobin saturation is a little bit less than 80%, while in the systemic arterial pressure, the oxygen levels are about 100 millimeter mercury, and you'll see here that the hemoglobin is about 100% saturated with oxygen. Now again, how is it that it lets go in the tissue? We have to this is the part of the oxygen that is going to be unloaded at the tissue level. There are certain factors that help that to happen. Okay, and these are the factors that we're going to be talking about. In order for oxygen to be let go, we call that dissociation from hemoglobin, okay? And you want this curve to go down, okay? And we'll see it in the next couple of slides, and we call that shifting the curve to the right. So we'll take a look, or maybe later, okay, but just keep that term in mind when we talk about these different curves. The oxygen that is used by the tissue has to be free from hemoglobin, okay? It cannot be attached. So the oxygen that the cells are going to eventually use are your free oxygen molecules. Now we're going to do this little experiment where you have 2 different, you've got water in each of these and oxygen molecules that are dissolved. Okay, you see here that The pressure of oxygen across that barrier is equal on either sides. If you add hemoglobin to the equation, and you see here that it's a darker purplish color, so it's a deoxygenated hemoglobin, each one of these will attach to 4 oxygen molecules. And when that happens, that means that some of these oxygen molecules are going to go across that membrane. Because remember again, the oxygen molecules that are attached to hemoglobin do not count. They're not active. The active oxygen molecules are the ones that are free. So our new equilibrium would be having these 2 free oxygen molecules here and 2 free oxygen molecules on this side. So this shows you that oxygen that is attached to hemoglobin is not active form. It cannot be utilized by the cells. So again, how are we going to shift that curve to the right so that hemoglobin willingly lets go of oxygen in order for the cells to use? So how is it that oxygen is transported to begin with? So this right here represents what happens in the lungs. So here the oxygen is inhaled through the alveolus, it diffuses into the capillary. Some of that oxygen is going to remain as dissolved oxygen. So these are your free oxygen molecules that can be utilized by the cell, while the majority of the oxygen is going to be transported as oxygenated hemoglobin or oxyhemoglobin. And that'll be transported to the tissue. Now that we reach the tissue, that dissolved oxygen can be utilized by the cells. But again, it's definitely not enough. So that oxygen molecules have to be dissociated from hemoglobin in order to be used and consumed by the cells and utilize it to make for different metabolic reactions. Now, these are the curves that we're talking about. So how is it that the RBCs make sure that hemoglobin is always able to let go of its oxygen? The red blood cells, keep in mind, do not have mitochondria. Okay, so remember, they were not nucleated, they did not have any organelles, and that's why their lifespan was only about 120 days. Because of the lack of mitochondria, they do not have the ability to go through Krebs cycle or the electron transport chain. They can only do glycolysis. And one of the byproducts of glycolysis is 2,3-DPG. That stands for 2,3-diphosphoglycerate. And that high levels of 2,3-DPG makes it easier for hemoglobin to let go of oxygen. So these 2,3-DPG that is found in the red blood cell but is not found in the tissue is going to make it easier for hemoglobin to let go of oxygen. So you see here that this is normal. This is a red blood cell without any DPG. But if you add DPG to equation, that curve shifts to the right, which translates into that hemoglobin is now going to let go of oxygen a lot easier. Okay, no DPG at all. Okay, here you see there's pretty much no dissociation. Now this curve down here illustrates the effect of temperature. So this is your regular body temperature at 37 degrees with a normal dissociation curve. In the case of fever, when there is an increase of metabolic demands because of that fever, you see here that again the curve is shifted to the right in order to unload that oxygen and provide more oxygen to the inflamed or infected tissue. Now, other levels or other factors that play in would be the high acidic levels that are found in the cells. So these cells, as they are going through metabolism, they are producing carbon dioxide. And again, carbon dioxide is going to eventually make these cells more acidic. So the presence of that high acidity, again, shifts that curve to the right. And now a little bit on the relationship or comparison between an adult hemoglobin in the mom and a fetal hemoglobin. So how is it that the baby makes sure that it always gets oxygen even if the mom doesn't have enough? That is because fetal hemoglobin has a higher affinity to oxygen than an adult hemoglobin does. So that ensures that the fetus is always going to get the oxygen it needs despite having lower oxygen levels if the mom does. Now, a little bit on anemia and carbon monoxide. So these are obviously not normal things that happen, but in anemia, Okay, now this patient already has a low hemoglobin level, so you want to make it easier for that less than normal hemoglobin to let go of oxygen. You don't want to make it harder. So that curve you see has been totally shifted to the right. This is your normal blood curve all the way up here in yellow, and this is a patient with anemia where, again, it's very easy for the hemoglobin to let go of the oxygen to these tissues that need it. In the presence of carbon monoxide, so in carbon monoxide poisoning, it is easier for hemoglobin to let go of oxygen, but the thing is that it is going to attach instead to carbon monoxide, and hemoglobin's affinity to carbon monoxide is about 210 times more than its affinity to oxygen. So hemoglobin is going to attach to carbon monoxide and not let go of it. Okay, so now oxygen actually doesn't have any opening spots or any available spots to attach to hemoglobin, and that is what leads to hypoxia and explains carbon monoxide poisoning. This is a summary of the movement of carbon dioxide. So here is the carbon dioxide is being produced by the cell. By diffusion, it goes into the capillary. There are three different ways how we can carry carbon dioxide to the lungs. It's either just dissolved carbon dioxide, okay, or it is attached to hemoglobin, and that is known as carboxyhemoglobin, or carbon dioxide, that infamous reaction that has been haunting us, where carbon dioxide associates with water through carbonic anhydrase enzyme to make H2CO3 or carbonic acid. That breaks down to HCO3 and hydrogen. That HCO3 leaves the red blood cell in exchange for a chloride, which is also negative, and that exchange is known as the chloride shift. Now this red blood cell is going to circulate to the lungs, and at the lungs, everything is going to be reversed. So that dissolved carbon dioxide can easily diffuse out of the red blood cell and then diffuse out to the air sac. The hemoglobin, that hemoglobin plus the carbon dioxide, that can also dissociate easily, and that reaction will go backwards. So the chloride will exit, bicarbonate goes back in, attaches to the hydrogen ion to make the H2CO3, and that breaks down into water and carbon dioxide. Now, again, that carbon dioxide can easily diffuse out of the red blood cell and then diffuse through the capillary into the alveolus. So this is a little illustration of the different centers for respiration. We have a center in the pons that is known as the pontine center or the pneumotaxic center. We also have we have these two centers in the midbrain, one in the towards the frontal side, and that's known as the ventral respiratory group, and there's one towards the back, and that's known as the dorsal respiratory group. And as we breathe in, okay, that breath in is going to stretch the alveoli, okay, and because of that stretch of the alveoli, that is going to send an impulse to inhibit or to stop inhalation. So basically, by default, we are always going to be inhaling, okay, unless it is stopped. So when we inhale, when the air sac stretches, stimulates stretch receptors, that is going to turn off these centers in the pons, that will eventually turn off these centers in the medulla oblongata. And that reflex is known as the Herring-Brewer reflex, and it prevents the overinflation of the lung tissue. Okay, things like morphine, barbiturates, fentanyl, heroin, those are going to suppress the medullary inspiratory neurons, and that can lead to death due to overdose by these medications because of the stoppage or cessation of breathing. Now, where do we have chemoreceptors to detect changes in oxygen or CO2 in the bloodstream? Just like the baroreceptors, they're found in the aortic arch, and they're also found in the carotid bodies at the bifurcation of the common carotid artery. The stimuli for the central and the peripheral chemoreceptors. So we didn't really talk about the central. Central chemoreceptors are found in your CNS, while the peripheral chemoreceptors are these, okay, your aortic and carotids. So we'll talk first about these peripheral chemoreceptors. Those respond to changes in the blood levels in the arterial blood, and they are stimulated either by severe hypoxia, so significantly decreased pressure of oxygen levels. They are also stimulated by increase of hydrogen ion concentration, which is known as metabolic acidosis. So for example, in diabetic patients, if they get to that stage of diabetic ketoacidosis, so they have an increase in hydrogen concentration levels that is going to stimulate these receptors, and they are going to start hyperventilating. Or in cases of respiratory acidosis, where there is an increase in pressure of CO2, and that's also going to stimulate these receptors. So a respiratory acidosis could be, for example, somebody that holds their breath for a very long period of time, okay? That is going to lead to accumulation of CO2 in the blood, and that increase of CO2 leads to that person is going to have to start breathing again. Okay, now for the central chemoreceptors, and those are going to detect changes in the extracellular fluid surrounding the brain. So in the CSF, basically, and these are stimulated by increased pressure of CO2, but not directly, because CO2 cannot pass the blood-brain barrier. It is, again, that equation that we talked about thousands of times, where that hydrogen ion has the ability to cross the blood-brain barrier, and it is the presence of high levels of hydrogen ions that will stimulate these central chemoreceptors. And actually, your central chemoreceptors are more sensitive than the peripheral ones. You can see here the changes that happen in ventilation during exercise. So that increase, that very acute increase in ventilation can even happen before you exercise. So just thinking about it or preparing to exercise, your breathing rates can go faster, even before you start. And then you can see there's a gradual increase of in breathing rates, and it kind of flattens out a little bit. And then as you stop exercising, there is a decrease. It still remains high for a period of time, and then it gradually goes back to normal during the recovery phase. So what is it that stimulates the respiratory center during exercise? There is the motor cortex. So your motor cortex, the frontal lobe, is going to send stimuli to the skeletal muscles to exercise. And at the same time, it's also going to send motor impulses to the respiratory center to increase or to stimulating breathing. Your skeletal muscles, through proprioception, will also send stimulatory impulses to the respiratory centers, joints as well, through those proprioception. And the that adrenaline rush or the epinephrine rush, increase in the plasma epinephrine, is going to stimulate respiration. Temperature, so as your metabolism goes up, your body temperature goes up, and that is going to also stimulate respiration. Conditioned response, so just thinking about exercising can sometimes stimulate the respiratory center. And then these changes in pressure, so the changes in levels of O2, CO2, and hydrogen ions, those kind of also through the chemoreceptors, those tie into stimulation of these breathing centers. Okay, and that concludes this chapter.